Well, hello everyone, and we are so glad that you have joined us today. We want to thank you for taking the time to join us for this important webinar. Just to make sure you're in the right spot, I'm sure you are. The title of the webinar is called Time to Act: What You Need to Know About Medicare's Proposed TAVR Decision and How to Lend Your Voice to Make a Difference. And at the end of today's live webinar, we'll have time for questions and answers from the experts who are joining us today. And throughout the webinar, as you have questions, feel free to type your questions into the chat log, and we'll respond either during the webinar or during the Q&A period at the end. So I'm Susan Strong. I'm Director of Patient Engagement for Heart Valve Voice US. I'm also a heart valve patient myself. And Heart Valve Voice supports early detection, optimal treatment, and better health for the more than 11 million people living with heart valve disease in the U.S. And you can find Heart Valve Voice online and on Facebook. And we invite you, if you haven't already, to join our Heart Valve Voice U.S. Patient and Care Partners support group. It's on Facebook. We're fortunate today to have two guests who will be sharing information on, for you at the webinar. Our first guest is Sue Peshin, and she is President and CEO of the Alliance for Aging Research. And if we could make sure we're all muted, that would help everyone to be able to hear. And Sue, you were part of a group of organizations that made a joint statement in response to the CMS proposed national coverage decision regarding TAVR. And we'll be looking forward to hearing more about that soon. But first, we're going to hear from Dr. Peter Pelican, who is the Medical Director for Coronary and Structural Heart Intervention at Pacific Heart Institute. Dr. Pelican, you and your colleagues initiated the request to CMS to revisit the national coverage decision. I was wondering if you would share with us why that you did that and explain how the process has been.
Be happy to. Thank you very much. So the NCD, as it was formulated about whatever it is, 6 or 7 years ago, when TAVR was a brand new and fairly risky procedure, allowed certain hospitals to perform TAVR based on what their procedural volume over the past year or two was for open heart surgery, valve cases, for cardiac catheterization cases, and for coronary stent cases. The startup of TAVR actually went quite well, and over the past 7 years, the procedure has become tremendously safer. The outcomes have improved. There are now training programs. There are now plenty of experienced physicians performing the procedure. So because the NCD was restrictive and basically restricted the procedure to high-volume hospitals, not necessarily high-quality hospitals, I and my colleagues here in Santa Monica submitted a request for Medicare to change the NCD. They actually accepted that request. In July, we had a one-day meeting where multiple people spoke, including me, including a number of colleagues here. And the points that I and others made in favor of changing the NCD was that there really is not a good relationship between procedure volume of a procedure and how well that procedure is done. Even though you might think, you know, if you play the piano more, you're going to play better. Actually, when you're learning to play the piano, that's true. But once you're an accomplished pianist, you certainly don't have to practice as much as when you were a student learning it. So if all we do is look at hospitals and make a decision as to whether they can perform TAVR solely based on their procedural volume, we are ignoring the fact that there are, first of all, there are high-volume hospitals that are not delivering quality, And second of all, there are low-volume hospitals that are performing at high quality. So Medicare, there were people who disagree with this. All of those people who disagree with it are based at high-volume hospitals who want to restrict all the TAVR patient care and therefore business to their hospitals. Medicare, last month in March, came out with a revised or proposed revision to the NCD, which on the one hand I would say is good in that it relaxed some of the procedural volume requirements, but on the downside it still is sticking to procedure volume, not quality, and therefore they will go on and allow low quality but high volume hospitals to do this procedure. And while they, as I said, relax the procedure, for example, instead of the hospital. Is my computer working now
for this?
I'm sorry? Hello?
I think so, because I don't have one of those holes. I think our computers are different.
Is it possible to mute everyone except for the speaker, is whoever's handling the webinar?
Should I keep speaking?
I think
Keep
it's good
going,
now.
Peter.
Thank you, Dr.
You're good.
Kogan.
So instead of having to do 400 stent cases a year, now they're requiring 300. That will, of course, allow some other hospitals to do TAVR, but I'll just make the point again, no matter how many stent cases you do, it has nothing to do with the quality of TAVR that you produce in your hospital. And consider if you're a TAVR program and it's December, mid-December, and you've only done 275 stent cases in your hospital, the next 25 patients who might be benefiting from open heart surgery, there will be an undue and unethical pressure for that hospital to say, well, we better do 25 more stent cases or we're going to lose our TAVR program. So I have written a rebuttal to the Medicare revisions, again, requesting that Medicare use quality, not procedure volume, and use that as a determining factor as to which hospitals can do TAVR. I hope that you all, everyone on the phone call, you can go to the Medicare website and write in comments. The word quality, unfortunately, does not even appear in the NCD document. So the way it stands, it's relaxed things a little bit, but it's still promoting this more, bigger is better, more is smarter, as opposed to quality.
So Dr. Pelican, if there was one thing that you could encourage the patients listening to do, especially between now and the 25th at the end of the comment period, what would it be? What would you encourage the patients listening to do?
There, as I said, I hope you provided a link to the Medicare website so they can comment. And
there is thank you. There is a link on the Heart Valve Voice website, I know for sure, that goes directly to that comment page. So go ahead.
We are in a 30-day open comment. Anybody who has an opinion is allowed to comment, and what would support our point of view would be to comment and say, abandon procedure volume and let's use quality as a determinant of which hospitals should do TAVR, because the goal is to provide quality procedures. I'll also add that in March, several research studies were released showing that TAVR, which currently is only available for middle risk and high risk surgical patients, currently the data suggests that even in low risk patients, TAVR is better than surgery in terms of death rate, in terms of stroke rate, et cetera. So once the FDA and Medicare allow us to do TAVR in low risk patients, the volume of this procedure is going to mushroom. Hospitals are not going to be able to take care of that volume of patients, and patients who need the procedure are going to get sick while they're waiting. So we need to allow this procedure to spread now that it's a safe procedure, and we have trained physicians who collaborate with one another. So writing in on the Medicare website, abandon these archaic 20th century, bigger is better, volume equals quality concepts, and move to measure quality and use quality to determine which hospitals should be delivering quality care to our patients.
Thanks. Dr. Pelican, I have one more question. Do you think that the way things stand with this current proposed NCD, that underserved areas, rural areas, places like Wyoming that still doesn't even have one TAVR center, areas, you know, where there might be underserved populations that currently don't have TAVR centers, would the current proposed NCD kind of continue to limit that in terms of people's access to TAVR?
It clearly will. I should also mention that because of drugs like Lipitor, if you look at the overall number of stent cases per year, it's dropping across the country. And the reason it's dropping is because Lipitor is an effective drug. So if we restrict TAVR programs to doing a certain number of procedures, stenting, those numbers are dropping across the country. Even though the criteria are somewhat relaxed, they are still restrictive. It is going to be tough to get a TAVR in Wyoming. It's going to be tough to get a TAVR in my town in Los Angeles, in South Los Angeles, where we have cultural, distance, driving, et cetera, barriers to getting health care at the 3 or 4 or 5 large hospitals that currently deliver that care. They're all backed up, they're all busy, and it'll be a little better, but it ain't going to be great.
Right. Thank you so much for sharing your time with us. I know you're very busy and you're treating patients, and you took the time out to explain to us today, and we're really grateful. And do you have time to stay around for the question and answer at the end? That's wonderful. Thank you so much. And now we'd like to direct our time to Sue Peshin. I was wondering, Sue, if you could tell us more about the importance of that joint statement that was written in response to CMS about the proposed NCD.
Sure, Susan, I'd be glad to. And Dr. Pelican, I just want to echo Susan's thanks. I thought that was terrific. You really laid it out very well. And I'm going to repeat certain points that Dr. Pelican made, but maybe hopefully in a little bit of a different way so that you all have as much information as possible when you give your comment into CMS. So a big part of what's been going on the last few months for us at the Alliance for Aging Research is that we've developed really wonderful partnerships with other organizations, and they include Heart Valve Voice, who we're co-hosting the webcast with today, but also Mended Hearts and the Association of Black Cardiologists. And there's a couple of other groups who have also been joining with us on occasional calls, and we've kind of come together under this umbrella called the Heart Valve Disease Policy Task Force. And we submitted a joint statement once this proposed decision just came out just a couple of weeks ago. And right now we're working on a formal comment that we're going to send in to CMS. And that's a big part of what we wanted to talk with all of you about today, is how to go about doing that. So I'm going to walk you through that during the rest of my talk.
Thanks, Sue.
Sure. Do you want me to go through my slides, or do you have another question you wanted to ask?
Oh, no. If you want to go ahead and go through all your slides at this point, that would work just great. Thank you.
Okay, sure. And these are going to be posted on the Heart Valve Voice US website and also on our website at agingresearch.org. So you can check these out after we're done. And it also includes another link, to the CMS website. But there's a direct way that you can get right to CMS on the Heart Valve Voice website. And I'll talk about that in just a couple minutes. But first, I want to just give you guys a brief background, and Dr. Pelican gave a little bit of this, but this has been going on now for about 7 years, a little over 7 years. A little over 7 years ago, the Food and Drug Administration approved TAVR for people who weren't able to have open heart surgery and who had severe symptomatic aortic stenosis. And then in 2012, CMS, the Centers for Medicare and Medicaid Services, and they're the ones who run the Medicare program, issued something called a national coverage determination for TAVR under something called coverage with evidence development. And those are, it's a whole lot of words to basically mean that they had a special policy for this procedure. Most procedures and services that you get under Medicare don't have national coverage determinations, and they don't go by coverage with evidence development. Medicare uses this in cases where it's a newer technology or a newer procedure, and they want to make sure that there's still evidence that's being collected along the way, maybe because they think more and more people are going to become eligible by FDA to be able to take advantage of it, and they just want to make sure that it's as effective as possible for the Medicare population. In this particular case for TAVR, they approved it for both FDA and non-FDA uses, and they had different qualifications for being able to use them. If you were going to use them in a hospital for something that wasn't FDA approved, you had to make sure you were participating in a clinical trial. If you were doing the procedure on someone who had an FDA-approved indication, then you had to enter all the information about that case into a national registry. And as Dr. Pelican mentioned, in addition to all of that, there were a whole bunch of other requirements that hospitals had to meet, including making sure that they did a certain amount of this procedure, the TAVR procedure, the surgery procedure, the stent procedure, as he mentioned before. So there were a whole bunch of things you had to do, and then also requirements for the type of professionals that had to be in the room. So you had to be super serious about wanting to do this if you were going to have it at your hospital. So now, this has been going on for 7 years, and this registry has more than 200,000 cases in it, and there's more than 50 published papers from all the clinical trials. CMS is now taking another look and saying, do we still need all of this or not? And that's where you all come in, because we would love for you to weigh in with your story and your thoughts about what you think CMS ought to do. So the first point that we're making in our comments together with some of the other groups is that you don't need all this evidence development any longer. This has been going on for a while, and that the available evidence is more than enough for CMS to say, you know what, this should just be covered nationally in all cases where you have FDA approval. And if you look at the studies where TAVR is compared to surgery, the results have either been that the health outcomes are similar, they're just as good, or they're even better. And in addition to that, for those of you who have gone through this, you know that TAVR, you have a shorter length of stay in the hospital, tend to have a faster recovery, and there are some better outcomes that you might even experience, including better quality of life. The second point is what Dr. Pelican really drilled down on, and that has to do with these annual volume requirements. So I'm not going to take too long on these, but one thing I think it's interesting for all of you to think about is that at the hospitals that offer these TAVR programs, they have to meet all these volume requirements. If you're a hospital that just offers surgery for valve replacement, you don't have to meet these types of requirements. So it's a little uneven in that regard, and it doesn't exist for surgery. And in our view, it kind of creates an uneven situation in the United States. And Dr. Pelican talked about this. It's much more common at larger academic hospitals in bigger cities, less easy to get access to in rural areas. And in a lot of rural areas around the country, they tend to take care of minority populations, poorer people. So it sets up a dynamic of unequal access. And that's one of the points that we really want to drive home. And in terms of people dying if they're having to wait for treatment, this is a really important point, because any of you who have gone through this, you know that the time to getting intervention, the time to getting your treatment is key, right? Especially if you're somebody who is experiencing symptoms. That's you know, when you're having quality of life issues, if you're not breathing as well, if you're feeling tired. And it really does show that even waiting more than a month can put you at a higher risk of developing heart failure or dying. And a lot of folks do this on an elective basis. So if this gets expanded approval to lower risk patients, you're going to have more and more people that are going to be eligible for the procedure. And if they don't change these requirements, you're going to start to have these long waiting lists. And we're concerned about that. The last major point is that this particular administration has a campaign that they're calling Patients Over Paperwork. And we're just trying to point that out to them, too, that it's important to put patients ahead of all these big requirements. It makes it harder if you're a smaller hospital to do all this stuff that's required. If it were still important and it still resulted in better health outcomes for people, that would be one thing, but we know it doesn't. So we just feel like it just is creating another barrier here. And, you know, it increases costs for smaller hospitals, so we just want to take away this barrier. Now, in terms of sending a comment to CMS, federal agencies aren't the best about making things easy for people, but we have tried to make it as easy as possible. Now, if you're going to put a public comment in, there is a deadline, and they're very strict about this. So you have to send something in by next Thursday, April 25th, and we put a link up here on this slide. There's also, like I said, you could go to the Heart Valve Voice US website, and that is heartvalvevoice-us.org, and you can click right on the Action Center. And there should also be a way to get to it right off the home page. So that's two different ways, and I'll mention that again before we close today. Now, once you get to the CMS website and before you put your comment in, they have something on there where you have to accept a posting policy, because everything that you put in there as your comment gets posted to the CMS website publicly, and you have to give them your permission to do that. So you've got to make sure that you click on that. They'll remind you. They're not going to let you post your comment until you do it, but I'm just telling you as to make sure that you do it. And then in terms of just a couple of tips for sending in a comment, really the most important thing is to make this personal. If you have a personal story, that's going to resonate. So if you yourself or someone that you care about has gone through open heart surgery or TAVR and you have an experience to share, start with that, because that's going to make them, you know, sort of perk up their ears and say, okay, this is really from the community, and that's what we're trying to get at here. And it's good for you to talk about why getting good treatment was so important to you. That's also going to be meaningful for them to hear. And then in terms of the messaging, we want you to make this your own. So a couple of things for you to think about, but put it in your own words. So we're encouraging CMS to expand access to TAVR and to remove overly strict requirements that have been put in place over the last 7 years. And also, again, if you have something to say about how you were or you weren't able to get the treatment you needed, add that in, because they want to hear about that. And then last, we're also really stressing how valuable it is for patients to be able to see how well their local hospitals are doing with both surgery and TAVR. Right now, you don't see any of that data, and that's what I was talking about before with there's over 200,000 of these cases in this big registry. And Dr. Pelican mentioned, we want to hear about what those results are. That means a lot more to people than how many procedures a given hospital does. And it's also a better indicator of how that specific hospital is performing. The volume stuff is a general thing. That's like a general association. It's like saying a lot of people eat ice cream in the summertime, but you can't tell whether or not your neighbor is eating ice cream, right? So it's not a specific thing that's going to let you know how your local hospital is doing in terms of these procedures. And we want to see that. So that's what this message is about. So we're urging CMS to change that, and that'll help patients to be able to make better informed choices about where they want to get their procedure done. Last thing is just an extra reminder, the deadline is next Thursday. You can't submit a comment after that, so we really encourage you. And if you have any questions, you can send them through the website. You can send your question. And then if you have any questions here, too, we'd love to hear them. We'd be happy to answer any questions you might have.
Sue, thank you so much. We actually already have 2 or 3 questions right now, and we encourage you, now is a great time to type into that chat bar to give us more questions. We've had one question that is an excellent question for someone wanting to know what is NCD. And it's the National Coverage Decision. But I was wondering, Dr. Pelican, would you like to explain a little bit more in depth what the NCD is?
Sure, I'd be happy to. So, again, when TAVR was basically invented and allowed to start in America, there was concern because it was a high-risk procedure. So Medicare issued the National Coverage Determination, NCD, which was a series of requirements for a hospital and physician to do TAVR. And I'm doing this from memory, but the hospital had to be performing 1,000 cardiac catheterizations a year. They had to be performing 400 or more coronary stent cases a year. There were surgical requirements. I think it was either 20 or 50 aortic valve surgeries per year for the past several years. So the NCD is the document that Medicare uses to determine whether a hospital will be reimbursed for performing this procedure. If you perform it without those criteria and you bill for the procedure, that's Medicare fraud, which is a felony as far as I know. You can't just tell the patient to pay cash, because if you're a Medicare patient, first of all, the cash is incredibly expensive, but second of all, if you're a Medicare patient, it's a crime to pay cash for a procedure that Medicare reimburses for. So it's effectively a set of restrictions that determine which hospitals, and as I said, they're basically high-volume hospitals, can do TAVR.
Thanks, Dr. Pelican. And my understanding is that NCD, the National Coverage Decisions, are not made on every single procedure that's out there, right? Is it only made on a few certain procedures, typically
That's exactly
newer
true.
ones?
So, for example, as was proven in these research studies, open heart surgery for aortic valve replacement is riskier than TAVR. There is no NCD for open heart surgery for aortic valve replacement. And really, as far as I'm concerned, we don't need an NCD anymore. We clearly, it was a good idea when it was a startup procedure, when the risk was high, when nobody in the country really was experienced. But now that we have experienced physicians, we have training programs, we have teaching programs, there's knowledge sharing, there's proctoring, the procedure has just become incredibly safe. And we actually, in our discussions with Medicare, asked them to just basically stop having an NCD. I guess for political pressure from the large universities that want to maintain their so to speak, monopoly on this procedure. Maybe Medicare is responding to that. I'm not certain, but I don't think the NCD is going to go away. So in that world where we're going to be stuck with an NCD, even though I don't think we need it, I would like it to be effective in doing what it's supposed to do, which is promote quality and not promote simply being a high-volume center.
Mm-hmm. Thank you. Sue, do you have anything to add to the question of what an NCD is?
No, I thought Dr. Pelican did a great job.
Great. Thank you. So we've got quite a few more questions coming in. Thank you, everybody. So the next question is, will you be posting this webinar on the Heart Valve Voice US website after the call and sending the link to all those who signed up, and especially for those who might not have been able to dial in? Yes, we will post the link to the Heart Valve Voice website, and we will send the link via email to everyone who received a link of an invitation to the website. So we will be able to get that to you. Perhaps you would like to have it, even if you are here, to review. And then for all those who weren't be able to be with us live, you'll have access to that. So that's a great question. And the slides will be posted on the Heart Valve Voice US website as well after the webinar is over. So if you were able to listen, but for some reason weren't able to see the slides, you will have access to that later this afternoon, I would think. Okay, I've got another question. This one's for Dr. Pelican. It says, can Dr. Pelican share the studies on high volume, low quality hospitals and low volume, high quality hospitals? Where do we find that information in shareable format?
Well, there are a number of papers published showing correlations between volume and quality. They're actually included in the talk that I gave in July with slides. Sue, I don't know if you're able to provide that or give a link to the Medicare website. There's a study in the state of California looking at surgery outcomes versus volume. And while there seems to be a trend towards higher volume, higher quality, there clearly are high volume hospitals that are performing at poor quality and low volume hospitals that are performing at excellent quality. I don't have the actual references at the tip of my fingers, but perhaps, Sue, if you'd like, I can try to email those to Sue Peshin and she can get them to you.
Sure, we can also try to, if we email a notice around to folks, we can send you a couple of key studies and references that talk about that. No problem.
And you can send my slides,
good question.
which have all of them with the references on them.
That sounds like a great deal of really helpful information. Thank you. That's really generous of you. Are we ready for the next question? Okay, so the next question we've already brought up. The question is there an NCD then for SAVR open heart surgery? And it's already been mentioned that there is not. And then the question goes on to say why the double standard in terms of the TAVR approval process requiring 2 surgeons and 1 interventionalist signing off. Okay, sorry, I probably shouldn't laugh. Do interventional cardiologists have to approve someone getting open heart surgery? But anybody want to take that question on?
It's Pelican again. I'm happy to answer that. So it's a multi-part question, but briefly, surgery has been around a lot longer than TAVR. Surgery started before NCDs existed, so that's why there's no NCD. Number 2, patients are referred by cardiologists to surgeons, but if a patient went directly to the surgeon, no, they do not have to get the approval of a cardiologist to operate.
Okay, thank you.
And if I can just add to that, 7 years ago when TAVR started, as I said, it was a risky procedure. We needed open heart surgeons in the room. There were, unfortunately, patients who the procedure didn't go well. Their chest was opened in the cath lab. They were put on bypass. They did open heart surgery on them, sometimes effective, sometimes not effective. The chance now, 7 years later, of needing open heart surgery is so low that whoever asked this question, I agree with you, we don't really need a surgeon to be present. The once a year catastrophe that needs to go to the operating room, you can always call the surgeon. But to have the surgeon in the room participating in the procedure, this is really a cath lab procedure. It's done by interventional cardiologists. It also happens to be done by cardiac surgeons who are trained in using catheters. But if there's somebody trained to do TAVR who is able to work with catheters and deliver the valve, having another person in the room as an open heart surgeon, in my opinion, is unnecessary. And in multiple physician operators who do this procedure, it's completely unnecessary.
Yeah, the only other thing I would add.
When we went to electric trains, and we still, by union rule, had to have a fireman on the train, even though we're not shoveling coal into the furnace on a steam engine, that's kind of where we are with this, in my opinion.
Interesting analogy there. Sue, did you have something else?
Yeah, I just wanted to add, I mean, I think it's a good question, and the other issue that we often point out is that when you go to a hospital that offers TAVR, they are required to talk to you about surgery as a potential option. But in the opposite case, when you go to a hospital that just offers surgery, they're not required to mention to you that TAVR may be an option for you. So when we speak about this national coverage determination, we point this out because there is a bit of a double standard going on at this point.
And as a patient myself, I find that really concerning. So the next question is, and do you have any feedback from those 200,000 cases? Do you know what that question's referring to? It's not quite connecting with me.
I think the question is referring to the National Registry. Its name is, the formal name is the TVT Registry, and it's organized by the Society for Thoracic Surgeons and the American College of Cardiology. And the sites that perform TAVR do, input information about each of these cases. They were, for a while, putting out annual reports on all of the data, on the aggregate data, but the last annual report was about 2 years ago. In 2016, it went through cases up through 2015, so we haven't seen a report since that time, but there have been a number of reports on this sort of volume outcomes relationship since then. And otherwise, there's a number of other folks that have asked to be able to use the data and perform analyses on it. And there's been a lot of studies that have come out using that data, looking at issues around disparities, looking at specific health outcomes, looking at how certain subgroups of people, like if you have a certain condition, how they do with the procedure. So yeah, there is definitely output on that data, and it's good. It's useful to have. But in our view, it would be particularly useful to have it by facility, and that's what's kept private, and that's not accessible to folks. So if you wanted to know specifically how things were going here, for example, in Maryland at Shady Grove Hospital, you wouldn't be able to find that out.
We've got about 4 more. this one is more of a statement, but one that I can relate to. The person says, I had a TAVR about 18 months ago. I was diagnosed with severe aortic stenosis, but I was denied the procedure by 2 major hospitals in San Francisco because I was still, quote, eligible for open heart surgery. As a patient, I talk to people regularly who struggle with being told first off that they're not eligible for TAVR, but then being able to go somewhere else with a lot of effort on their part and end up finding out that they can have TAVR. And as was said earlier, I think the kind of double standard, the disparity, the not being told the same thing across the board is a difficult thing for patients and really unfortunate. Would you guys like to comment on that? Or
it's Pelican again. Hopefully I'm not hogging everything up here, but
of course not.
I mean, that's going to change as soon as low-risk patients are allowed to be treated with this procedure. On the other hand, there's still, in the new NCD, they require 1 surgeon to approve it, not 2, as I read the document. But it's still going to be a surgeon who may say, no, I disagree, and then you're going to be in trouble. So we are still in a world where in many parts of medicine, the physician really can advise the patient. It's ultimately the patient's choice, but in this part of medicine, it's not ultimately the patient's choice. I just had a patient in the past month who would have been, probably served very well with a TAVR. She's a low-risk patient and ended up having open heart surgery because she just did not qualify for TAVR. And there's no way around that. So would hope that the restrictions would be relaxed and physicians could continue to try to do the best for their patient rather than following a rule book.
Yeah.
Right.
I completely agree, and it is unfortunate now because of these volume requirements. They have to meet certain thresholds. So there's sort of an incentive to drive people in one direction or another depending on where you are in the volume requirements. And that's not really how care should be delivered to folks. You should be explaining to them what their options are, talking it through. If people are eligible and it's appropriate, most folks would want a less invasive procedure. That just makes sense. But unfortunately, because of these volume requirements, there's sort of a push-pull with what to recommend to patients. And to us, that sort of takes it out of being real care.
I couldn't agree more.
Last 2 questions we have. If the number of TAVR procedures a hospital, let's see. I think we've got a word left out. If the number of TAVR procedures a hospital does isn't an indication of their ability to perform well, what should be used instead to make sure that patients go to the best hospital?
Again, can I answer that?
Sure.
So there are 2 different points here. Number one, the number of coronary stent cases performed has nothing to do with TAVR quality. And then if we just to take a step back, and this data is in my slideshow, which hopefully Sue will be able to forward to everybody. In the old days, when coronary stenting was a young procedure, there was a volume-quality relationship. As that procedure has expanded with safer stents, with more knowledge, with more training programs, with more collaboration between operators, it has really, the last American College of Cardiology statement in, I think it was 2013, basically said it's hard to detect any relationship between procedure volume of coronary stenting and outcome. So to say you're going to do better coronary stenting by doing more coronary stent cases, maybe, maybe not clear. To say you're going to do better TAVR because you're doing coronary stent cases at a certain volume is completely ridiculous, including you could have 30 doctors doing 10 cases each or one doctor doing 300. Now, is one of those better than the other? Because all they're looking at is hospital requirements. So now moving on to the second way to look at this, does doing more TAVR cases make you a better TAVR hospital? And interestingly, there were two publications, one by Marty Leon about a month ago, which showed there is no longer a learning curve for TAVR using the Edwards SAPIEN 3 valve. It's such a good valve, and there are so many training programs. So there does not appear to be even a learning curve for that procedure. And he basically refutes the volume-quality relationship. There was last week a paper published in the New England Journal of Medicine, I think an unfortunate paper in a way, in that they looked at 100,000 patients in this registry, and their conclusion was there's a significant difference between high-volume and low-volume hospitals. Well, when you look at it in detail in the paper, it's statistically significant, and the difference, and again I'm quoting from memory, is in the high-volume hospitals, the mortality rate is 2.6%, and in the low-volume hospitals, it's 3.1%. Now, the difference between 2.6 and 3.1 is 0.5. Whether that number is medically meaningful or not, you could make a strong argument that's really not a difference. They use so many patients in there that they attain statistical significance. So their conclusion, rather than their conclusion being, look at how good all these hospitals are, rural hospitals at low volume, big university hospitals in urban centers at high volume, the difference is minimal medically. They took so many patients in there in the study that when you take a huge number of patients, even tiny differences become statistically significant. So unfortunately, their conclusion, I disagree with it, was it was a significant difference. It really medically was not, statistically it was, but in terms of the outcome from lower volume versus higher volume hospitals, you wouldn't notice the difference, basically. I don't know if that answers your question.
To follow up on that, on the last bit of the question was what should patients use to get the best care? You know, what should a patient have in mind, or what type of research should the person do, or you know, what kind of maybe some guidance for patients who are looking at finding the right facility to have a TAVR?
Right. So in the old days, we believed that patients were all wise and all knowing, and if a program was busy, that's because the patient who knew everything about everything was going to that place because it's great, and therefore high volume reflects greatness. We now understand that high volume reflects Medicare allowing you to do the procedure, insurance company or HMO contracting, patient choice, marketing, driving distance, et cetera. So volume isn't really the way to look at it. Medicare does require every TAVR procedure to be put into a database. That database is not available to anyone to search. There are arguments pro and con in terms of making database data available to the public because the database is sometimes difficult to interpret. For example, if you're doing TAVR on super high-risk patients, clearly your outcome numbers are not going to look as good as if you're doing TAVR on people who are extremely low risk. Because anytime you do a procedure on a high-risk patient, it's going to be higher risk and more bad things will happen. If the database was perfect at adjusting for those risk parameters, then yes, publish it. There's a lot of argument as to how well databases like that really do adjust for such risk parameters. But again, I think Medicare should be determining whether a center, based on Medicare's assessment of this database, can do TAVR or not. And then if you got the Medicare seal of approval based on the Medicare committee assessing, then you should go to that hospital. Unfortunately, that's not happening right now.
Susan, this is Sue. I just wanted I just wanted to make a couple extra points to what Dr. Pelican just said. I mean, that is sort of what we're interested in. I totally hear what he's saying about the registry and whether or not they risk adjust well, but the TVT registry does risk adjust for both in-hospital mortality and 30-day mortality, meaning if you die in the hospital, the time that you're recovering from the procedure or within 30 days of having the procedure. And they do risk adjust for hospitals that might take sicker or older patients or frailer patients. So they have that information. And actually, in fact, New York State, through their Department of Health, they print out they make available an annual report on cardiac procedures. So not just TAVR, but if you have open heart surgery, for stenting, you can actually see what the results are at the local hospitals throughout New York. So that's already being done, so it is possible to do it. And in terms of asking or giving advice to folks about, how to make sure they're going to a good place, I mean, everybody who's on here now certainly is educated, and you can talk to your friends and people that you know to make sure that they understand that there's more than just one option for treatment for aortic stenosis. There's both surgery and there's TAVR, because they may not get the information at the hospital that they're going to. So from our perspective, the sign of a good place to go is hopefully is a place that offers both or talks to you about both and goes through the benefits and risks for your particular situation on both of those procedures so that you understand what your options are.
Sue, we are down to our last question, and it really dovetails nicely on what you just said. So I'd like to put that question out there, and then it'll be time to soon wrap up because we've just about spent our hour together. It's gone quickly. So the last question is, what if a center doesn't offer TAVR? Is there a requirement that patients should be made aware of where they can get TAVR? In reviewing all the options available, even if not a particular center, and how will this be managed? And maybe this is an opportunity for change. I'm adding that because I'm not sure that there is something standardized about this. What do you have to say about that?
There is no requirement. If you're going to a hospital that just offers open heart surgery, for valve replacement, they're not required to mention TAVR or to direct you to a hospital that offers TAVR. You can get in touch with groups like Amended Hearts or, Heart Valve Voice to sort of learn about options. And they can also further direct you to some places where you can learn about the hospitals that do offer both procedures. So that's really the best way. There's no requirement now for that.
Would that be something people could comment about if that concerned them in their comments?
I do think it is, to me, a double standard that we point out quite a bit is that, at the TAVR hospitals, they are required to talk to you about surgery, but it's not the same at a place that just offers open heart. So it's a valid point. And, given the one person who raised it as a question based on their personal experience, it's good to share that in your comment to CMS about that experience because, just as people, we should all be given the benefit of, here's what's available. We may not have it here for you at our hospital, but, you may want to explore it at local hospitals, and it is a shame that people aren't given all the information that they really should be hearing.
True. Well, do either of you, Sue or Dr. Pelican, have any last words you would like to add before we close up our time together?
I would just encourage everybody to get on that Medicare website and make some comments. And thanks for the attention and for listening.
Dr. Pelican, you're awesome. Thank you. I just want to remind people the deadline's next Thursday by midnight, so you got to do it early, and tell your friends about it. And you can go to heartvalvevoice-us.org and click on the Action Center, or just click on the alert that's right on the homepage. And thank you guys so much for tuning in today to listen.
Yes, thanks everybody, and check your email boxes. We'll be sending some more things to you shortly today. Thank you.
Thank you. Bye-bye.
Bye-bye.